I'm Amin. I'm an associate professor in old age psychiatry and an honorary consultant working across the University of Southampton and Hampshire and Isle of Wight Healthcare NHS Foundation Trust. I'm going to give a brief overview of some of the dementia research updates that I think it's important that you know as clinicians and also dementia researchers online. And I'm going to focus on three areas initially. So dementia prevention, dementia diagnosis, and dementia treatment. So I'm going to mainly focus on Alzheimer's disease when I go through that pathway, but some of the learning points I think apply to all causes of dementia. After I've finished about 15 minutes of going through those areas, I'm going to hand over to Dr. Brady McFarlane, who'll go and cover some of the local updates on dementia research as well. So the first area that I wanted to cover is dementia prevention. Now, I think this is really, really important, impactful work that's been published in the last few years, looking at how dementia can be prevented or the onset delayed significantly if certain risk factors were mitigated or eliminated. It's not really fancy research. It's not, doesn't receive a lot of headlines. It doesn't. It's not a wonder drug or a magical diagnostic test that you can use in your clinic, but I think it's got the potential to impact our clinical services and society immensely. This work has been led by Jill Livingstone, and it's population-based or epidemiological research looking at certain risk factors and how they contribute to dementia incidence later in life. I think the initial paper was published in 2020, where it presented 12 potentially modifiable risk factors for dementia. That's all-cause dementia. In the recent update last year, they added two more to that list. So they added vision loss and high cholesterol to the previously identified 12 risk factors for dementia. And I often have to think to myself just how impactful this could be. So essentially, this paper is saying that we could prevent or significantly delay at least nearly half of dementia cases if we eliminated or significantly reduced these risk factors. So I think that's got the potential to make a huge difference in terms of patient outcomes, carers that have to give up work to look after their loved ones with dementia, healthcare systems, the economy, social care. But obviously, I think the clear message is that it's much easier said than done to modify a lot of these risk factors. And some of them, I would argue actually all of them, potentially have a really significant focus on public health messaging and investment on a population level. So things like air pollution, education in early life and midlife, some of the strategies around obesity and achieving healthy weights. These are all things that obviously we can do some things on an individual level, but there are clear discussions that need to be had on a national level in terms of public health messaging. I think it's really important to mention this in a dementia conference because obviously a lot of these risk factors are risk factors for other conditions like cancer, heart disease, asthma. But I think we need to fly the flag as OPMH clinicians and researchers and really put dementia out there as one of the conditions that could potentially benefit significantly if there was more of a focus on dementia prevention. I run a tertiary memory assessment clinic at the Memory Assessment and Research Centre, which is at Moor Green Hospital, about 10 minutes down the road. I'm not sure which direction. My navigational skills are terrible. And at the end of my clinic appointments, when I see people with either mild cognitive impairment or age-associated cognitive decline, I usually actually show the left-hand side of this slide to patients and relatives. And I do that because before I did that, the end of my appointments were pretty drab. I was, giving people the news that they had MCI, telling them that they, what I thought was the cause of their MCI and what I thought might happen to them. But actually, I didn't know whether they were going to go on to get dementia or not. And all I could really say was go and see your GP again if you get any worse and come back. This framework really helped me to give some tailored individual risk factor guidance for my patients. So obviously tailor this on depending on their past medical history and any other sort of social factors as well. But I think it really helps empower the patient and the relative to work on things that will not only help potentially reduce their risk of dementia, but also to improve their general health and well-being. I think the obvious point is that we can't necessarily extrapolate epidemiological or population-based research down to the individual patient level. So I can't say to the person in front of me that if you mitigate these 14 risk factors, your risk of dementia will be 45% lower. That's not how the dementia, these dementia research studies work. But I still think it's an important conversation to have with patients, and it will ultimately help not only perhaps reduce their dementia risk, but also help their general physical and mental well-being. And I think it also just helps improve that conversation with the patient as they go out of the door and give them some power to do things themselves. And it only takes a couple of minutes at the end of an appointment as well. So I'm just going to briefly cover a couple of key points around dementia diagnosis. The first couple of points on this slide aren't really research updates, but they're just for some reflections that I've had with conversations with neurology colleagues and old age psychiatry colleagues, and things that I've noticed when I've sort of been moving around the country at conferences. There's still a lot of variability when it comes to accessing timely structural brain imaging and also timely functional brain imaging like FDG PET CT. I remember sitting in a Royal College conference with, I think it was Professor John O'Brien, talking about 10 years ago at one of the old age faculty conferences, encouraging the audience to go away and speak to your neuroradiology colleagues in your areas and actually try to work up a conversation with them, ask them or tell them what you need from reports. And I'm really lucky now that the patients I send down to Lymington have absolutely excellent neuroradiology reports and contain exactly the information that I need to help with my diagnostic pathway for my patients. So my message is really, it is possible to do that. I know it might be more difficult when you're near a tertiary academic centre, but yeah, please do try and have those conversations. I'm more than happy to try and facilitate that as well. There's also a lot of variability when it comes to accessing Alzheimer's disease biomarkers. So at the moment, we can access Alzheimer's disease CSF biomarkers through our neurology colleagues. I know Ross Dunn, an old age psychiatrist up in Manchester, has managed to set up a lumbar puncture clinic in his memory assessment pathway. So there is the possibility of innovating and actually having new clinical pathways that can help support diagnostic services in your own centres. So if you want me to put you in touch with Ross, I'm more than happy to do so. And he's very, very open with the challenges that he encountered and how to set up those services locally as well. The reason for mentioning perhaps some sort of not so positive updates is to really give you some context into what I think is a really exciting area of dementia diagnosis currently. We're going to hear from Professor Jonathan Schott shortly about blood biomarkers for Alzheimer's disease. So I found out only last week that we can, I can now request plasma p-tau 217 from Southampton General Hospital, much like we request lymphoconcapitis auto-antibodies. The blood test will get sent up to UCLH. So it's possible that we can do that now. There's still a lot of work to do in terms of validating these blood tests in clinical settings and determining how clinically useful they are in the diagnostic pathway. And Professor Schott's going to be talking about some of the research studies around that and how we could potentially utilise them more routinely in clinical practice. But I think that's a really exciting area. Blood tests for Alzheimer's disease is something we've used at our research centre for many years, usually as part of the screening process when we're determining eligibility for research trials. But the fact that we can now potentially request them for our NHS patients, I think is a real game changer. They aren't diagnostic, but then neither are brain scans or cognitive tests that we do. But I think putting all of these interventions and investigations together could really improve the accuracy of our diagnosis of Alzheimer's disease. The last couple of slides I wanted to cover are around dementia treatment, and I'm going to focus primarily on Alzheimer's disease here. I know that many of you already know about these two anti-amyloid immunotherapies. So we've got donanemab and lecanemab. These are drugs that are given by intravenous infusion every 2 or 4 weeks and are now licensed in the UK to be used in early Alzheimer's disease. So for people with mild cognitive impairment or mild dementia due to Alzheimer's disease. I'm sure many of you know there's been quite a lot of controversy about the extent of clinical benefit that these drugs might have, at least over the initial 18-month period that the trials were done. And there's also some concern about their side effect profile as well. So I'm sure, again, many of you know about the amyloid-related imaging abnormalities, or ARIA, that can be caused by these drugs, where you can get cerebral edema or cerebral hemorrhages as a result of these drugs being administered. And there are also some concerns about cost effectiveness. So these are drugs that are given every 2 or 4 weeks in a hospital setting via intravenous infusion, and obviously the staff and estates costs associated with that, but also the fact that they need patients need regular MRI scanning to monitor for those brain side effects as well. So NICE published I think it's their final draft. I'm not sure how many drafts they've got, but it's supposedly their final draft guidance on these 2 drugs in the last fortnight, and they've said that they don't meet their safety and cost effectiveness thresholds for recommending for use on the NHS. So they're available privately, but not on the NHS currently, which is obviously disappointing to many patients and families. But I think there's some important work that's going to happen over the next few years to see whether we can modify some of these drugs to see whether they might meet thresholds for safety and cost effectiveness over the next few years. So there's one example of that is there are now 2 trials including these drugs that are happening over a much longer term. So the initial trials were done over 18 months, looking at clinical and safety benefits. These drugs are now being trialled over many years to see whether they truly change the disease trajectory for people with Alzheimer's disease and keep them independent and in the milder stages of dementia for a significantly longer period of time compared to people who aren't on treatment. So I think that's really interesting and exciting work that we'll hopefully be able to find out about in the next couple of years. Another aspect to this is how some of the drugs are being changed in terms of their administration method. So there is now a research trial that's looking at subcutaneous self-injection of this class of drug to see whether that might be more of an acceptable treatment method. It'll obviously cut down on costs significantly because you won't need a hospital setting or staff to provide an infusion. And there are also trials of drugs that are potentially bypassing some of the significant side effects that you can get with these drug classes. So I think over the next few years, we'll have some updates on these drugs and their class, and potentially hear about how they might be able to be, there might be a step change in their cost effectiveness sort of analysis, and how NICE might review that in the next couple of years. So watch this space. My last slide is quite busy, so forgive me. It's a chart published by Jeff Cummings every year, who summarizes the dementia, so the Alzheimer's disease drug development pipeline. And I show this to you as primarily clinicians in the audience to really illustrate a couple of points. So one is just how much work is going on in dementia and Alzheimer's disease research alone in terms of interventional trials. There's a huge amount of work going on. On the outside of this chart, you've got phase 1 trials. These are usually early stage, so first in human or first in disease group. Going on to phase 3 trials in the centre. So these are trials that are testing effectiveness in healthcare settings. So you can see that there are lots in phase 2 and phase 3, which we'll hear about in the next few years as they read out their results. I think what's also interesting is it's not just disease-modifying drugs that are being tested at the moment. We've also got other types of drugs that are testing whether they can be cognitive enhancing or testing neuropsychiatric symptoms. And I have lots of conversations with colleagues about just how difficult neuropsychiatric symptoms are to treat in dementia. I used to work on an inpatient dementia ward where it was, had some challenges in terms of treating neuropsychiatric symptoms. So I think it's important to know that there is lots of work going on in that area as well in terms of symptomatic relief, but also some of those really difficult to treat neuropsychiatric symptoms. There are also, I think it's important to note from this slide, that different mechanisms that are being targeted. So I think yellow is inflammation. We've got dark blue for tau, red for amyloid, and lots of other targets for these drugs. So yeah, I think my main point from showing this slide is that there's lots of work going on in the Alzheimer's disease field, and I think in the next few years we'll have some really important updates potentially, and hopefully we'll have some disease-modifying drugs or symptomatic treatments that are licensed for use in the NHS. Well, that's the dream anyway. That's why we're all doing the job that we're doing. That is everything from me. So thank you very much for listening. I'm going to pass over to Dr. Brady McFarlane, who is a consultant in old age psychiatry and director at the Memory Assessment and Research Centre. I am incredibly grateful to Brady for all the work that he's done in terms of bringing some of these clinical trials to our patient population locally. It's fantastic. We've got such a range of trials that we can offer our patients across the region, and that's all down to the team at MARC and Brady. So over to you, Brady.
My name is Brady McFarlane. So I'm an old age psychiatrist based in the New Forest, and I'm director of MARC, so the Memory Assessment and Research Centre. I'm very happy to be here today. And thank you very much for that introduction, Jay, although I'm a little bit underwhelmed, to be honest. So I've been campaigning for years to be known as Dr. Brady McFarlane, the hardest working old age psychiatrist in the country. And although some people might dispute that, I cover the area with the highest dementia prevalence rate in the UK. Although actually, if you look at that at different times, it does change. And when I looked at it yesterday, I was third. But Dr. Brady McFarlane, third hard-working old age psychiatrist, doesn't have quite the same ring to it. So, but actually, the high prevalence of dementia locally means research into dementia isn't just professionally relevant, it's deeply important to our communities. Many of you know, recently we became part of the new Hampshire and Isle of Wight Healthcare Trust, following the coming together of Southern Health, Solent and the Isle of Wight trusts. And we're now one of the largest community trusts in the country. So with our demographic profiles, we've got older populations, we've got coastal retirement areas, significant rural areas. We've got a real concentration of people living with dementia. And that gives us both the responsibility and an opportunity to do research where patients are, so not just in major academic centres. And as a community trust, we're incredibly well placed to lead on this. It's hugely encouraging. We've got our Chief Medical Officer, Deputy CMOs and Director of Research here today. And every conversation I've had with them about the formation of the new trust, it's clear that there's a genuine appetite for research and innovation. I think that's really exciting. So today, following on from Jay's excellent talk about the big picture of dementia research, I want to give you a brief look at what's happening in dementia research locally, particularly at MARC. I want to share a little bit about things that we're proud of, what we're working on, and why I think this is an important area to be involved in. So MARC is the Memory Assessment and Research Centre. We're based at Moor Green Hospital in Southampton. Over there, Jay. We're I think, multidisciplinary team. We've been conducting dementia research locally for over 30 years. You've seen our official team photo in the slide before. This is our casual one. So the brief was, look more human, pretend to laugh at each other's jokes. I find banter and general social skills difficult, so I'm staring ominously into the camera. Our research spans mild cognitive impairment and dementia, particularly Alzheimer's and Lewy body dementia, increasingly also including preclinical studies, so people with normal cognition, but with a positive biomarker, particularly blood tests. We're proud to be ranging a wide range of studies, so both commercial, so studies funded by pharmacological companies, but also local grant-funded studies as well. I hadn't planned to go into any detail about trials today, but I did think I'd just give a flavour of the kind of things that we're doing. So Clarity AD, this is the lecanemab study, which is now in open label extension, and that means that we know that people aren't on placebo anymore, so everyone's getting the drug. So lecanemab, this is a monoclonal antibody, so that's basically working like antibodies that we produce in our bodies, in this case manufactured to bind to amyloid beta protofibrils and remove amyloid plaques from the brain. People come to get infusions every 2 weeks for that. We've got 2 separate trials with Lilly at the moment, one for donanemab, which, as Jay mentioned, is another monoclonal antibody. The other's a preclinical study trying to target people earlier in the disease pathway before they have any significant cognitive symptoms. And just this week, we've started a trial with Merck. So this is a drug, so for those of you pharmacologically minded, this is an alpha-7 nicotinic acetylcholine receptor type 1 PAM, or positive allosteric modulator. So basically, I think that it's meant to enhance receptor activity in the presence of an agonist. But the way that I understand it is basically give it to people with donepezil and it helps donepezil work better. where are we next? Cognicat. So Nestlé sponsor this trial. This is a nutritional supplement with various long-chain ketones and B vitamins to see if it could help with people with mild cognitive impairment. We've been running this for years now. This is Novo Nordisk do Evoke and Evoke Plus. So these are GLP-1 agonists before they became trendy. So before they became ubiquitous as the diet drugs. And the theory is that these drugs improve insulin sensitivity, aiding glucose metabolism and overall brain function. I don't know if Professor O'Brien will mention these, but these are two Lewy body dementia trials. So Top Hat is looking at ondansetron, which is an anti-nausea drug, to see whether that will help with hallucinations in people with Lewy body. And Top Hat, and so Cobalt is adding memantine to people on cholinesterase inhibitors with Lewy body. So that's a really good example of something that we all do in clinical practice, but actually it's trying to develop some evidence to see whether or not this is actually working. We keep our website up to date with all of the trials we're running, and I'll share that at the end. But if anyone wants to know any more detail about trials or anything that we're doing, please get in touch with me, and I'll be very happy to talk about things in more detail. So I just want to highlight some of the things that I'm particularly proud of, starting with our work in Lymington. So for those of you who don't know, Lymington's a beautiful sailing town in the New Forest. It's home to a small but fantastic community hospital that our trust manages. It's got about 100 beds. We've been running monoclonal antibody infusion trials there for about 6 years now through the medical day unit. And I think it's a really interesting place to deliver these studies. So this is Chris and Mary with Jackie, the MDU manager. They're normally doing medical things like giving people iron infusions and that sort of thing, but the team there have helped create a brilliant research infusion service, and I think it's a really good potential model for how we might deliver future therapy. So it doesn't necessarily, I think, need to be in a huge academic centre in London or Oxford, but a well-run district hospital close to where people live. And I think that's a really good example of research delivery that's patient-centred and accessible and delivered in a community trust. So this only works because of the amazing teams at MARC and at Lymington. Given this conference has a particular focus and it's part of the Wessex OPMH academic programme, I did want to highlight the contribution of our resident and specialty doctors. So their involvement's been absolutely crucial to everything that we do. And I really want to encourage more trainees to spend time with us. So either it's just a visit as a one-off or spending regular special interest sessions, we'd love to have you. It's a great experience, really good for CVs. Many who've done it have said that it helps shape their career direction. So come and talk to me or come to any of the doctors who, most of them are here today. One resident doctor said to me that their time at MARC had, and I quote, opened the door to other career avenues outside of full-time clinical training and fundamental in their decision to continue higher training in Wessex. So I think that kind of impact is fantastic to hear, both for the individuals involved, but also really good for the trust as far as recruitment and retention and all that kind of thing that we love to have. So I'm not sure we're there yet, but we continue to work on memory assessment pathways throughout the trust, and I'm really keen that research is truly an integrated part of that. So I'd love for us to be in a place where everyone that we see with MCI or dementia is offered the opportunity to take part in research if that's something that they want. I want to take the opportunity to thank all of you for continuing to send people to us. So we're always incredibly grateful for all of your support. The expansion of our trust means we've got even more opportunity to reach areas that we perhaps haven't had before. So, for example, we're giving donanemab at the moment to someone who gets the ferry over from the Isle of Wight to Lymington. So there's lots of things that are possible. And for referrals, we don't need any detail. Just drop us an email, give us a call, copy us a clinic letter. I'll leave the details at the end of the talk. We just need names, really, of people that are interested in research. So, I went to my first in-person conference this year since the pandemic. I went to the Old Age Faculty Conference in Liverpool. That's where I trained at medical school. Lots of highlights. I just wanted to highlight this poster that I loved. So this was titled The Wrong Trousers. So some of you might remember the Wallace and Gromit reference. And I thought it was fantastic. So this is a real audit from an old age dementia ward in Northern Ireland. And it looked at how many patients were wearing their own clothes on the ward. And they found just 20% of people were wearing their own clothes. So 80% of people were dressed in someone else's trousers or their own, other people's glasses or other people's shoes. And obviously the distress and the risk that caused was significant. So they had some kind of intervention, and then their aim was that by the end of the intervention, they'd have 80% of people wearing their own clothes. And I thought, that's great. And then I thought, only in old age psychiatry would that be seen as an ambitious target, that 80% of people on a ward would be wearing their own clothes. And I guess it made me reflect on some of the conversations that I've had with people about the cost and the delivery of monoclonal antibodies. So especially following NICE's decision not to recommend lecanemab or donanemab due to modest benefits and high resource needs, as Jay was saying. So it begs the question, shouldn't we be focusing on getting people dressed in their own clothes before we start infusing them with expensive medicine? But I don't believe that those two things need to be mutually exclusive. So I think we need to aim high in both directions. So, we could aim for the stars, get 85% of people in their own trousers, but we could also keep pushing for the very best in diagnostics, imaging, treatment, and research, because I think there's a really exciting time to be involved in dementia. So we've got the beginning of the first disease-modifying drugs. We've got blood-based biomarkers allowing earlier, less invasive detection. And the fact we're a community trust means that I think we're ideally placed to bring this to patients and their families. We're not pulling money from other services, so MARC is self-sustaining, often through commercial research income. We're often in surplus, and research benefits our patients, our staff, and our outcomes. So I'd love everyone involved to feel that it's a great time to be working in dementia, and involvement in research is a really positive thing that we can be offering our patients. So we're doing okay for time. So what I would like to do, if that is okay, indulge me in showing you a video. So this is about 5 minutes. This is brand new, produced by AI UK, who are generously supporting our conference today. So normally, when you see videos about dementia, they're about how devastating the disease is. And I think that's very understandable. I think AI UK are quite excited about this because although it still is very moving, it also aims to promote some hope about the value of research. So it features Larry and his wife, Rita, who we know very well, as Larry's been coming down to Lymington for the last 5 years to get his lecanemab infusions. It's also got some nice footage of the setup at Lymington, and also some nice pictures of Larry cycling down with the seawall, where he goes after he's had his drug, and it's one of my favorite places in the world. So I love this, and I hope you indulge me with watching it for a minute.
I think to contribute to any drug trial is a gift. There are many, many people in the future who will have this disease. The sooner we get to that cure, the better. The more drug trials that we run, the more people who partake, the faster we'll get there.
My name is Larry Welk. I was born in Dodge City, Kansas, moved over to this country in '77, and have been here ever since.
Larry and I met in 1970 in Boston. We were both working at the same hospital. And he was very cute. And he drove this little sports car, and I used to get allergies. So every time he wanted to put the top down, I had to make him put the top back up again. He was the first guy that I dated who was more interested in what I wanted to do when we went out than what he wanted to do. I used to call him sometimes the absent-minded professor because he would be so in his own head that he wasn't listening. And I was accusing him of not listening. And I kept saying, but I told you that, we're going to go there and then we're going to do that. And he wasn't absorbing it. And I didn't think that much about that until we went to Boston, where my son was living then. And he noticed that Larry's memory was slipping.
When the diagnosis came through, Rita and I would talk about what the long-term effects is. Now, it's difficult to predict, but having my mother who went through it, I could see what was down the road.
Larry's memory problems started 8 years ago, so we've had 8 years of dealing with his memory loss. And I feel, and he feels, extremely fortunate that we happened on this drug trial?
The trial is an infusion every 2 weeks. The staff providing the trial are quite supportive, quite friendly. In fact, I would say they're as much as friends and family and not just clinical trialers, if that makes sense.
I do feel fortunate that we looked it in the face and said, yes, we need to get some help with this. And that diagnosis, having come so early in the game for Larry, got us on this route, on this journey at a time when he could be helped.
One of the things with a clinical trial is you never know what the outcome's going to be, and sometimes there's no real benefit or outcome at all. But with this trial, I feel I have quite benefited. There are things that when you get old, you forget things like, why did you go into that room? And what channel is that program on? But my memory, had slipped a little bit more than normal, going back 4 or 5 years. Now, on lecanemab, it hasn't slipped a lot. I take memory tests every 6 months, and those really haven't changed in the 4 years that I've been in the lecanemab trial.
Well, when I think of my sister and I think of Larry's mother and friends of ours who have Alzheimer's, and I just think if you could somehow avoid that in the future. Not every drug trial out there is going to be beneficial, but every drug trial is going to tell the researcher something about that drug. So that's the reason to be on a drug trial.
I really think that video is something different, and I think it's a very good message. So this is our email, telephone number, and website address, and that's the end of my talk. Thank you.